It's my great pleasure to introduce our next speaker, Dr. Olu Ajilore, who's now at the University of Illinois. And I just learned today that he's been there. How many years have you been there? 15 years. This is the first time he's been to Madison. Yeah, I heard an oh no. So anyway, we hope that this is the first of many trips to have you come back and visit our department and to hang out in Wisconsin or in Madison. Olu's going to give us, I think, a really interesting talk related to, as you can see, mood and cognition in the interface. But what's, I think, most exciting about this is his work related to bringing together multimodal imaging in ways that hopefully are more informative than the way that we currently think about using our specific imaging methods and also some of the computational methods that he'll be talking about. But what I think what's even more exciting or related to his work is his efforts to use the understanding that he's generated and is generating from the data to think about new treatments and new ideas about treatments, including digital treatments. So he's very much on the cutting edge of not only thinking about how to bring together different types of imaging data to inform us about normal emotion cognitive interactions as well as psychopathology, but also from the standpoint of thinking about applications of that. And we're going to hear more about that. Currently, Olu is the Associate Head for Faculty Development at the University of Illinois. He's also the Professor for the Center for Depression and Resilience at the University of Illinois as well. He received his bachelor's degree from Harvard, did his MD and PhD at Stanford. I just learned with Dr. Bob Sapolsky, who was actually one of our very early speakers, and Olu's early work was related to glucocorticoids and stress, a topic that you heard a lot about already, and is a theme obviously that runs through a lot of the work that we do. Then went on to UCLA to do his residency and internship there, and actually went to the Medical University of South Carolina and got a master's degree in clinical research, which is, I think, probably enabled some of the thinking that he's done in relation to clinical trials. As I mentioned, he's the Associate Head for Faculty Development in the Department of Psychiatry. He also is the Director of the Mood and Anxiety Disorder Program there and co-director of the MSTP program as well. In addition to that, if that isn't enough, he also directs the Clinical Research Corps for the Clinical and Translational Science efforts there, the grant that they've received at the University of Illinois. The department there has really, I think, had a huge transition over the over the period of time that Olu came there. And he's been a big part of that. And it's really great to have you here. Let's give him a warm welcome, and we're excited about hearing your talk.
So first of all, I want to thank Ned and Richie and everybody here in Madison for inviting me to be a part of this symposium. This is a group that I've admired from not so far for many years. And I'm really honored to be in a symposium with other speakers whose work I've long admired. So today I'm going to talk a little bit about a bunch of different projects that we've done in the lab. And I first want to start with my disclosures. All of the work that I'm going to be talking about was funded by NIMH, but some of the work that I'm talking about at the end of the talk has been commercialized in a company called Keywise AI. So after a brief introduction, I'm going to talk about how we can think about using brain network metrics as predictors to treatments to standard treatments like cognitive behavioral therapy or pharmacotherapy with SSRIs. And then I'm going to talk about how we can use brain network characteristics to inform novel treatment development. And then I'm going to expand our notion of what networks mean to talk about the network of digital devices that we interact with on a day-to-day basis and how those devices can help us determine insights about mood and cognition and their relationship in the context of mood disorders. So I apologize if you've seen me talk before and you've seen this slide, but this gentleman, Sir John Batty-Tuke, is sort of like my good luck charm for talks, because I came across his lectures about 10 years ago. This man was the president of the Royal College of Physicians in Edinburgh in the late 1800s. And he was also a very early proponent of some of the biological theories behind psychiatric disorders at a time when people thought that mental illness was due to moral failings. But he had a strong belief that we could better understand how to treat patients that were dealing with these disorders if we could better understand the brain. And if you want, you can actually read some of his lectures. They're available on, I think, Google Books or Google Scholar. But he had this amazing collection of this lecture series called The Insanity of Overexertion of the Brain. And one of the passages out of these series of lectures really struck me, where he talked about the fact that, you know, a lot of the understanding of how the brain was related to psychiatric disorders were just, you know, mere hypotheses, but that one thing that was pretty clear was that mental action is a function of connections, so that when those connections are destroyed or disrupted, there's going to be an impairment of function. And this was a like sort of early sort of proto idea that disruption of network characteristics in the brain could give rise to psychiatric disorders. And this is something that was realized 150 years later by NIH in a funding announcement where they basically said the same thing. But what was really interesting was that they said that, you know, when we think about disruption of brain connectivity, that we typically don't think about them in the etiology of psychiatric disorders like we do with neurological disorders. But, you know, I just showed you that somebody talked about it 150 years ago. But what's different now is that we have the technology to better understand how disrupted connectivity can give rise to these psychiatric disorders. And that's the approach that we've taken in our lab, where we've taken a brain, we've abstracted it into a network or a graph where we can characterize these connections. And then we apply graph theory functions to this network to characterize metrics that might be associated with different psychiatric disorders, and as I'm about to tell you, response to treatment. And we can use all kinds of different modalities to construct these graphs or networks. We can take data from gray matter parcellation atlases to derive the nodes of the network. We can look at correlation of the bold signal from fMRI scans to define the edges of the network, or we could look at the number of tracks from diffusion tensor imaging to define the network structurally. And so once you've defined this network and you've applied graph theory metrics, then you can characterize how the brain functions as a network and how it doesn't function in the context of psychiatric disorders. And two of the most common graph theory metrics that you'll see in the literature, and the ones that I'll refer to later in the talk, are path length or network efficiency and nodal centrality or a measure of network influence. And path length could be simply thought of as a number of edges that link any two given nodes in a network. In this case, between nodes I and J, there are 3 links. So the path length would be 3. The inverse of that is the network efficiency. So longer path lengths are related to lower network efficiencies and vice versa. Another graph theory metric that you'll see in the literature is nodal centrality, which refers to the hubness of a node in a network. And what I'm showing you here is the air transportation network. And I flew out of Chicago O'Hare, which is a very common hub for a number of airlines. And this notion of what makes a node a hub relates to its influence over the entire network. And sometimes having too much influence can be a problem, like it was last night when I was trying to fly out to Madison and I was stuck on the tarmac for 3 hours. And that's an example where a node with too much influence can be a problem, but we can look at nodal centrality or the hubness of a node as a sign of its importance to the overall network. And there have been a number of studies that have looked at these graph theory metrics in the context of mood and anxiety disorders. For example, it's been shown that there's a reduction in global brain network efficiency in association with social anxiety. Our lab and others have shown a reduction in network efficiency in mood disorders, and these reductions in network efficiency correlate with clinical symptom severity, so higher levels of depression, higher levels of mania associated with lower brain network efficiency, as well as cognitive features associated with these mood disorders like processing speed. So our lab and others have shown that impairments in processing speed are related to lower brain network efficiency. In addition, there have been studies to look at the nodal centrality and found that there's a higher degree of nodal centrality for limbic regions like the amygdala and the hippocampus, as well as regions in the default mode network in association with mood and anxiety disorders. So in the first section, I'm going to talk about how we use some of these graph theory metrics to look at predictors of treatment response to standard treatments that we use in our day-to-day clinical practice. And to do this, we use data from a study that was headed by Dr. Luan Fan when he was at the University of Illinois, Chicago. And he had one of the first research domain criteria or RDoC studies funded by NIMH, where the idea was to take a transdiagnostic approach to studying these disorders by finding constructs that apply across diagnoses that might be tractable from a biological mechanism understanding. And so he was interested in focusing in internalizing disorders. So these are disorders that encompass major depressive disorder, social anxiety, generalized anxiety disorder, panic disorder. And the reason why he wanted to focus on internalizing disorders was the idea that they shared underlying neural circuits where there might be alterations that are important in the pathophysiology. And more importantly, from a clinical standpoint, we use the same treatments to treat all of these disorders, namely cognitive behavioral therapy and SSRI treatment. So the goal of this study was to take people with these internalizing disorders and randomize them to getting either SSRI treatment or CBT treatment. They did a whole host of neuroimaging before and after treatment to see if we can predict who will do best with what type of treatment. And the idea was to use neuroimaging to find what are the underlying circuits that might be informative in this prediction of treatment response to SSRIs or CBT. So I had a MD PhD student in the lab, Paul Thomas, who is now going on to become an anesthesiologist. And he looked at the RDoc sample and was interested in a couple of things. One is, can we use these network metrics to look at what's different between patients with internalizing psychopathologies and healthy controls? And can these differences predict treatment response overall, as well as treatment response in a modality-specific way? And this is just a plot showing the heterogeneity of this sample, where you have a lot of overlap between the anxiety and the mood disorders. And for his first analysis, we focused on the Uncinate network, which is a series of regions that you heard about in Dr. Ressler's talk in the prefrontal cortex, as well as the amygdala and the hippocampus, that are linked by a white matter tract called the uncinate fasciculus, shown in the right in brown. I have the hippocampus in magenta as a reference. But these are important regions involved in emotion regulation as well as emotional processing. And there have been a number of studies that have shown abnormalities in this white matter tract linking these regions in the context of mood disorders. For example, that Shalene showed there's an increase in white matter hyperintensities in this tract. Our group and others have shown associations with the integrity of this tract and depression severity. And there have also been functional changes shown in this tract. And then we've also shown that this occurs in late life depression as well as younger adults with depression. And so what Paul was interested in looking at was whether network characteristics of nodes in this sub-network, in the Uncinate network, were associated with differences between our groups. And he found that there was a reduction in the local efficiency of the left medial orbital frontal cortex, such that it was lower in patients compared to controls. But it also predicted treatment response to CBT specifically, and it increased with CBT treatment and correlated with overall symptom improvement. And that's shown in this graph, where we see an improvement in the depression, anxiety, stress scale was associated with improvement in the local efficiency of this left medial orbital frontal cortex region. And it's important to note that this network characteristic was defined based on structural brain network characteristics. So this is derived from diffusion tensor imaging. And what was really interesting about the specificity of this finding in the left medial orbital frontal cortex is that it aligned really nicely with work done by Bodie Dunlop and Helen Mayberg and others, where they had a similar study design looking at neuroimaging predictors of CBT versus medication response. And they found that the left medial orbital frontal cortex functional connectivity to the subgenual cingulate specifically identified people who would respond to CBT versus medication. So this was a nice sort of synergy between functional findings and structural findings from our study. The other approach that Paul wanted to take was to look at a more data-driven approach to find subnetworks that had these characteristics of being different between our groups of interest and predictive of treatment response. And to do this, he was interested in looking at network dynamics. How do we map how information flows across a brain network? And one way to do this is to look at the structure of the network. And the analogy is to figure out what is the flow of traffic in a highway system based on where the on-ramps are, where the off-ramps are, the number of lanes that you have. And so can we predict the flow of traffic by looking at the structure of the network? And that's what Paul did with the brain, where we could look at the structural network properties of the brain, predict how quickly information can flow based on that information structure and the structural topology of that network, and see if there are differences in that information flow between our patient group and our control group. And using this data-driven approach, Paul found a large subnetwork that involved parts of the default mode network as well as the salience network or singular-opercular network, where the information flow was significantly slower in patients compared to controls. Furthermore, there was a hub in this subnetwork in the medial anterior cingulate cortex that has also been identified as a key region in this multiple demand system. So the multiple demand system is a series of functional networks that are activated based on different types of tasks. And it's thought to be important in the coordination of cognitive functions across a wide range of tasks. And connections to that same hub region to other regions in this subnetwork were associated with symptom severity. They were predictive of treatment response overall, and particular links in the subnetwork were particularly associated with response to SSRI treatment versus CBT treatment. And so overall, this approach has shown that we can use both a hypothesis and data-driven approach to identify a subnetwork that delineates patients with internalizing psychopathologies versus controls and is associated with treatment response both in a general and a modality-specific way. And I would say that you'll probably hear later on this afternoon from Dr. Pascal Leone about how in neuroimaging and network characteristics have been very useful in informing ways of predicting TMS treatment response. And we have a part of this paper where we describe how we can use the same method to identify patient-specific targets for TMS as a potential application. So next, I'm going to talk about how we can use some of these network targets to develop novel treatments, first using fMRI as a modality. And I'm going to use data from a study that we did a couple years ago called SPEAK, which is a study of a problem-solving therapy-trained voice-enabled artificial intelligent counselor that is for patients with mild to moderate mood and anxiety disorders. And the reason why we focused on problem-solving therapy is that there have been previous studies that have shown that problem-solving therapy is particularly effective for patients with depression and comorbid executive dysfunction. And that's also been shown in the context of older adults with depression that have this executive dysfunction sort of subtype. Patients with getting this therapy have shown significant improvements in their depressive symptoms, as well as improvements in executive function. And when we think about the putative network targets of problem-solving therapy, we looked at the cognitive control network, defined here from one of Leanne Williams' papers, where she identified a cognitive subtype of depression based on neuropsychological tests and based on a task-based fMRI paradigm where she did a go, no-go task in the scanner and found that these patients with the cognitive subtype of depression had lower activation in the cognitive control network. They also had poor treatment outcomes as well. And so we wanted to see if our intervention that delivers problem-solving therapy through the Amazon Alexa platform could affect activity in this network. So I'm going to talk a little bit more about what this intervention involved. We used the Amazon Alexa platform based on its natural language understanding and natural language processing capabilities to deliver 8 sessions of problem-solving treatment over 12 weeks. This was also combined with a system that allowed us to record symptoms on a smartphone and track that session to session. We did an iterative design process where we involved patients who had had prior experience with in-person problem-solving treatment to tell us about their experience with the app, how easy was it to use, how fun was it to use, did they have good working alliance or therapeutic alliance with the actual app. And we had a number of lessons learned from that iterative design process, where we would reduce temporal and cognitive load by splitting up conversation segments. We also gave users more temporal control over the flow of the therapy sessions by adding repeat and pause functions. And then we also gave them some physical material to work through their sessions with, and then allowed them to get feedback on how they were doing session to session based on their PHQ-9 and GAD-7 scores. It's important to note that this was done several years ago, pre-ChatGPT. It took several months of development. Just as an experiment, I wanted to see if I could do this using ChatGPT. It took me about an hour to do what took several months of development to do a couple years ago. But based on these lessons learned, we deployed our PST therapy chatbot called Lumen. This is the flow chart. At baseline, we got a number of assessments to look at anxiety levels, as well as problem-solving skills, as well as coping skills. And then we also did baseline and follow-up task-based neuroimaging based on the idea that using this app should enhance activity in this cognitive control network during this task. These are the subject characteristics. I just want to highlight that it was a fairly diverse sample, mostly women. And what we found was that compared to a waitlist control group, there was a significant increase in activity in this cognitive control network in those patients that used Lumen compared to the controls. Furthermore, that increase in cognitive control activity was associated on the left with an improvement in problem-solving skills, and on the right, a reduction in dysfunctional coping skills. And that was sort of our target for this particular pilot study, which was done as a R61, R33, where we had go, no go criteria in the pilot phase of the study before we go on to a larger clinical trial, which we're in the middle of right now. We also saw pretty decent effect sizes on reduction in anxiety and depressive symptoms. Even though that wasn't the goal of the pilot, we still measured that. And we actually had a statistically significant reduction on the HADS hospital anxiety depression scale. One of the interesting things that we did was we looked at potential moderators of this clinical response. And what we found was that the participants that did the best with Lumen happened to be non-white women with a college degree of education or less. And that was a little bit counterintuitive, as well as another finding, which was that patients that did the best with Lumen also had the lowest digital literacy. So the first part, as I mentioned, was a little bit counterintuitive, but then when we look at the characteristics of the people that helped us with this iterative design process, they tended to be non-white women with a college degree of education or less. So it was almost designed for that demographic in the first place. The other part about the digital literacy was also a little bit counterintuitive at first, but then when we thought about it, if somebody is really tech savvy, they would probably have more difficulty with what we developed in terms of how clunky it was or how difficult it was to use. And if you're a little bit more tech naive, you might have been more forgiving of some of the hiccups that you would have experienced while using this app session to session. But I think an important lesson out of this pilot study is, in addition to the ability of using these brain network targets for a behavioral treatment, was the idea that if you have particular stakeholders involved in the development of your intervention, that's the group that's more likely to gain benefit from it at the end of the day. All right, so now I'm going to move on to how we've looked at network targets for novel treatments using EEG. And does anybody recognize who this dapper young man is? No? No guesses? So this is William James. And one of the things that he said in his seminal work, The Principles of Psychology, is thought is in constant change. And so the idea of dynamic brain states is another old idea that we can look at with new methods. And so that's what I'm going to talk about in this segment, where we were really interested in looking at dynamics associated with activity in the theta band. And this is based on work that was initially done by one of our former grad students, Maggie Xing, where she looked at an EEG-derived network. So we looked at the coherence of signals between different electrodes using something called the weighted phase lag index to define the edges. The edges of the network, and then the electrodes were the nodes of the network. And what she found across different frequency bands, that selectively in the theta band, there was a significant difference in patients with social anxiety compared to controls, such that they had a higher level of theta network connectivity compared to controls. So what you're looking at in the first column are the healthy controls, and the second column are the patients with generalized social anxiety disorder, and then the third column is the difference. Furthermore, these increases in theta were significantly associated with anxiety ratings done by these same patients, such that the higher the anxiety, the higher the theta network connectivity. And that was also reflected in the EEG network properties, where we saw a selective reduction in the path length in the theta band compared to the other bands. So inspired by that work, we were interested in focusing on theta, but while participants were doing the emotion regulation task. And in this task, participants are asked to look at an image that's designed to generate negative affect, and they're asked to do one of two things: either regulate that negative affect or maintain that negative affect, and that's compared to a neutral stimulus. And we were interested in looking at how this EEG network evolves over time while participants are doing the task. And to do this, we use a sliding window method. So we're getting these snapshots of EEG network activity or connectivity during the task. And then we use a technique called manifold learning and nonlinear dimensionality reduction to basically visualize how these brain states are changing over time in 3 dimensions. And that's what's shown in this next animation, where we're looking at basically how brain states are changing over time during the task in a state space that represents how the data relates to each other. And it's color-coded according to whether these changes in brain states are coming from the healthy control subjects or whether they're coming from the social anxiety subjects. And what you can appreciate is, if you look top down at these trajectories, is that they all occupy different parts of this state space. So for example, towards the bottom, you see all the trajectories from the healthy control subjects while looking at a neutral stimulus. And then here's when they're looking at a negative stimulus and maintaining negative affect. Here's when they're doing reappraisal. And then on the other side of the state space represents all of the brain state changes in the social anxiety folks. And you can appreciate how they sort of occupy more of these, more of the state space. And as they go from neutral to maintain to reappraise, those trajectories sort of occupy more and more space. One of the ways we can actually quantify this is to look at the trajectories, lengths of these trajectories. And when we did that, we saw a significant difference between the trajectory lengths of the patients with social anxiety compared to controls, particularly during the neutral and maintained part of the task. And what you can see is that if you just focus on the healthy controls, is that that trajectory length increases as a function of sort of cognitive demand. As you go from neutral to maintain to reappraise, you see this increase, whereas the social anxiety trajectories are sort of start elevated, right? And that's sort of reflected in this correlation plot here, where we're looking at the tendency to use reappraisal as an emotion regulation strategy as indexed by the ERQ as a function of trajectory length. And so the more that you're likely to use reappraisal as a day-to-day emotion regulation strategy, the lower your trajectory lengths. And so we think that this is sort of an index of the amount of effort taken involved in the emotion regulation task. And this is sort of reflected in a study that I threw in for Richie here on Vipassana meditators, where they looked at midfrontal theta activity during an emotion regulation task. And what they found was that these experienced meditators had a reduction in theta during no-go trials versus go trials. So they didn't sort of ramp up theta like the control subjects did, but they actually had better emotion regulation despite not ramping up their theta as much. And it's thought that the idea behind this sort of decreased ramp up of theta is that they're more efficient at emotion regulation compared to controls. And so this all feeds into the idea that what's happening in theta is that it's a reflection of the cognitive effort involved in emotion regulation. Oops, sorry, skipped something. So what I've just shown you briefly is that we've seen alterations in the theta band network associated with anxiety, and that dynamics in this theta band might represent this cognitive effort that I was talking about. So then I wanted to see if alterations in these network properties could actually serve as a target for an intervention. And so I had the fortune of attending Dr. Pascal Leone Center's training on TACS before I engaged in this pilot study where we were interested in taking a resting state EEG scan, using that data to generate an EEG-based network, find the pair of electrodes where we have the highest theta network connectivity as defined by the weighted phase lag index, and use those electrodes as targets for transcranial alternating current stimulation, and then see if that had an impact on the resulting EEG signal, as well as emotion regulation capabilities. And the idea behind this was that, if we can lower that baseline theta connectivity, maybe we can increase the dynamic range of theta available to participants to do the emotion regulation. And so this is the study design. We had an active control in TDCS, which was just placed over the left dorsolateral prefrontal cortex. Participants got stimulation either during emotion regulation or they got it during rest. And then it was counterbalanced whether they got verum stimulation first or sham stimulation first within subject. And we were interested in looking at the effect of this stimulation on emotion regulation, on clinical symptoms of anxiety and depression, as well as whether it can move the needle on some of our EEG measures. And so what our hypothesis was that the effects of TACS should be greater, this sort of targeted TACS should be greater than standard placement TDCS, which would be better than sham stimulation. And what we found is that on the left, if we look at the valence ratings, right? So basically, how negative does this image make you feel? We see that there was a significant reduction in those getting TACS compared to TDCS in the valence of their negative ratings. We also saw that this reduction did occur in the TDCS arm, but if they got the verum stimulation first. And then with the arousal ratings, we only saw this effect with TACS and only if they got verum stimulation first. So there seemed to be an order effect in place. And this is work done by Jessica McAleer, who's shown here. We also want to look at state depression ratings before and after stimulation, and we see that TACS, unlike TDCS, reduced state depression ratings after stimulation. But that was driven by those who got the verum stimulation first. So there seemed to be something about sham first that impeded the benefit of getting TACS. We also looked at state anxiety ratings where TACS did a little bit better than TDCS on reducing state anxiety ratings before and after stimulation. And then we also looked at heart rate variability as a physiological index of stress. Higher heart rate variability is associated with more adaptability and more cognitive flexibility in dealing with emotion regulation. And we see as a function of stimulation order, particularly in the TACS group, that there's a steady increase in heart rate variability. Now, you might be asking, where's the EEG data? And one answer is that didn't change in the way that we thought it would. And so we're sort of doing a deeper dive and looking at maybe some of the dynamics. So it doesn't change sort of the baseline level of theta anxiety, but it may change some of the aspects of the dynamics. So what we see is that in this section is that networks like the cognitive control network can serve as a target for interventions like Lumen that deliver problem-solving treatment, and that we can look at network dynamics as a target for interventions like TACS to enhance emotion regulation. So now I'm going to talk about expanding this idea of networks by thinking about the network of digital devices that we work with. And again, this is inspired by old ideas as well. So this is from the American Journal of Insanity, which is now better known as the American Journal of Psychiatry. In this editorial, they talked about how one of the things that we lack in psychiatry, and this is back in 1891, is methods for tireless observation of our patients, and that if we had these methods, we would be more precise, more thorough in our assessment of patients, right? So that's one thing that was lacking in 1891. I'm not going to comment about now yet. And then similarly in the Lancet in 1859, there's a passage in a piece where they talked about how one of the problems of trying to assess our patients in the clinic, in the hospital, is that they're removed from the context which contributes to their disorder in the first place, right? That they're removed by time, by locality, from the origin of the disease, right? They're taken out of all the surrounding conditions that contributed to their disease. And so that takes away our precision in making a diagnosis or making an assessment. And so now we do have some tools for tireless observation that allow us to capture information in our surrounding conditions, like smartwatches, smart speakers, cameras, sensors, phones. And again, this creates a network of connected devices that allow us to better assess behavior. And this is summarized in a nice figure from David Moore at Northwestern, where he talks about how we can use all these sensors to inform both lower level features, like phone usage, movement, activity, and how that relates to higher level behavioral features, which in turn relate to clinical syndromes like depression and anxiety. And in this last part of the talk, I'm just going to focus on one of these smartphone usage based on how you type on your smartphone. And this is the BioEffect app, which was developed by my colleague, Dr. Alex Liao, which replaces the default keyboard of your smartphone with a customized keyboard that allows us to track how you type. Importantly, we don't track what people type. And so by tracking how people type, we can infer information about the user's mood and cognition. And so in one of our first papers using the BioEffect app, we could take a bunch of keyboard features, and they were significantly associated with clinician-rated symptoms of mania and depression. And this is work published by John Zulueta. And he was also interested in looking at what keyboard features are unique to either mania or depression. And he found that less backspace usage was associated with more manic symptoms, more autocorrect or more typos was associated with more depressive symptoms. We were also interested in looking at whether these typing metrics could predict changes in symptoms prospectively. And in a paper published by Jonathan Stange, he looked at instability in typing metrics as a predictor of subsequent elevations in depressive symptoms. And he found that both instability in mood ratings as well as instability in typing speed predicted an increase in depression levels. And some of these findings have been replicated in an open science study where anybody with an iPhone can download the app, contribute data. To date, there have been about 2,700 folks that have signed up and contributed data. And in one of our first papers published, we saw that some of the same findings, higher PHQ levels associated with more typos and also more typing variability. In addition, typing duration seemed to be associated with higher levels of depression. We were fortunate to work with folks at the University of Michigan, where they also did neuropsychological testing on patients that use the BioEffect app, namely the trail making test and the Tower of London task. And in work published by Mindy Ross, she showed that typing speed was highly correlated with psychomotor processing speed as indexed by the trail making test, not only between subjects, so that slower typers were slower on the trail making test, but also within subjects, so that if you were slower on a particular day with your typing, you'd be slower on the trail making test. Another thing that we can do is look at the typing data as a time series by looking at typing speed as a function of key press order. And once we look at it as a time series, then we can apply all kinds of time series analysis to the typing data. And we did this in an analysis where we were interested in looking at entropy, or the regularity of this time series, so that if you're a regular typer, so that the timing in between each key press was regular, that's a low entropy signal. If it was more erratic, that's a high entropy signal. And we wanted to see if that was associated in work done by Alex Demos and John Bark with entropy of move times on the Tower of London task, where you have to get from a start state to a goal state in as few moves as possible. And we can look at the timing of those moves and look at the entropy of that to see whether you've thought about how to solve this puzzle in a planful way, or whether you're more impulsive or erratic, where you might have a very quick first move time to do it as quickly as possible, realize you screwed up, have a slower second move time. And so you won't have regular move times if you're doing it in a less planful fashion. And our hypothesis was that patients with bipolar disorder would do it that way. We would have more erratic move times in the Tower of London task. And furthermore, that would be reflected in their typing. And we found that in general, on the Tower of London task, the patients with bipolar disorder did have a higher move time entropy compared to controls. And then using multi-scale entropy, we showed that with typing, they also had higher levels of entropy. And those two things were correlated. So in the patients with bipolar disorder, typing entropy was significantly associated with the Tower of London entropy, but it was also associated with clinical measures, so variability in mood symptoms, as well as variability in impulsive actions and feelings. And so we can see that these passive ways of looking at the keyboard data can allow us to measure aspects of cognition. So I don't know if I'm actually really over time by 9 minutes or, okay. All right, so I'm just gonna wrap up. Oh, perfect. All right, so I'm gonna wrap up by talking about one of our current studies where we're interested in linking some of the stuff that I talked about in the first part of the talk, looking at brain network characteristics with digital markers to link mood and cognition. And we're doing this in an NIMH funded study called Unmask, where we're interested in looking at the link between affective symptoms and cognition in a transdiagnostic group of patients across the spectrum of mood disorders. And our goal with this study is to see if what we measure on the phone is related to what we can measure in the brain with regards to brain network correlates of cognitive dysfunction that we see in mood disorders. And we're recruiting patients, or we have recruited patients in any mood state. And the idea and rationale behind that is that cognitive dysfunction not only occurs within a mood episode, but they persist between episodes. And they're predictive of relapse, they're predictive of functional outcomes. And so we think that when we're looking at the association between typing metrics and things like mania and depression, what we're really tapping into are problems with processing speed and executive function. And that's what we're testing in the Unmasked study. So after a baseline assessment, we have participants using the BioAffect app for a month. And during that month, we do gold standard clinical and cognitive assessments to better validate some of our typing metrics, as well as multimodal neuroimaging that involves DTI to look at structural network characteristics, task-based fMRI doing a go, no go task, and resting state fMRI. And some of the things that we hypothesize are related to each other are based on our previous work and what others have done, looking at how things like typing speed might be related to processing speed and how that might be mediated through structural brain network efficiency. And one of the first things that we did was replicate findings about typing speed being related to trail making test performance in the Unmasked study. And one of the nice things about getting data from the smartphone is that people use their phones all times of the day, right? So we're collecting data across the entire day, and we can take advantage of that to look at time of day effects. And what we see here is that there's slower typing speed in people who perform more slowly on the trail making test. And there's also an exaggerated slowing of typing speed in those that perform worse on the trail making test. And that's shown in the top left. And in the top right, we're looking at typing duration also being associated with poor performance on the trail making test, so that people who type less were also slower on the trail making test. Furthermore, in a preliminary analysis, we've linked this to brain network efficiency, where we see that lower brain network efficiency was associated with slower typing, particularly in the morning. Another thing that we can do is that we have a task on the BioAffect app where they do a go, no go test at least once a day during the study. And we can look at performance on this go, no go as a function of depression severity across the day. And so we see some time of day effects on go, no go trial accuracy, where in general it's higher in the mornings and evenings than it is in the afternoons. And we see that the lowest accuracy occurs earlier in the day for patients that are more depressed. So we see some time of day differences as a function of depression on performance on this go, no go task. And we also saw this with reaction time, where actually we saw that there are time of day effects on reaction time on the go, no go task, but that was most notable on patients without depression. Those who had depression basically had slower reaction times as a flat line across the day, right? So there weren't any kind of diurnal variations in that. But that's the kind of analysis that we can do when we're collecting this dense temporal sample data. Another thing that we can do is use hierarchical drift diffusion modeling, which is something that was developed by Roger Radcliffe in the late 70s as a way to model different aspects of decision-making by looking at the distribution of reaction times on a two-choice task where you can make a wrong decision or you can make the right decision. And from this model, you can extract different parameters such as the drift rate, which is how efficiently you're accumulating information in favor of making a decision one way or another. And that's the drift rate. We can also look at the response boundary, which is how much information do you need to make a decision? And wider response boundaries means you need more information. It's also associated with being more cautious. More narrow response boundaries are associated with requiring less information, but also being more impulsive and maybe more apt to make the wrong decision. And then there's another parameter called T, which is the non-decision time, which refers to all the non-cognitive aspects of decision-making, perception of a stimulus, the motoric response. And we could extract all these parameters from the drift diffusion model. As long as you have a task where you have at least two choices where people can make the right or wrong decision. And in the unmasked study, we have that with our mobile assessment with the go, no go. We also have some neuropsychological assessments that we did based on the NIH toolbox, like the flanker task, as well as the dimensional change card sort task, which is an executive function task where you have to match on color or shape. And then we also have a task-based fMRI paradigm, the parametric go, no go, where we also have these distribution of reaction times. So I'm going to talk about how we've applied the drift diffusion models to one of these tasks, the dimensional change card sort task. First, I want to show you how well the mood disorder folks did compared to our controls. So they did more poorly as expected. And again, these are folks, some of them may be in episodes, some of them may be euthymic, but they still perform more poorly compared to their non-mood disorder counterparts. And when we applied the drift diffusion model to the data out of this task, we see that the drift rates for mood disorder patients were significantly slower compared to controls. They also had smaller boundary separation, which might be an indication of being more impulsive on the task compared to controls. And they had a slower non-decision time. So then the next thing I wanted to look at was, can we apply the drift diffusion model to typing data that we're getting from the BioAffect app? And to do this, we can think about typing speed as akin to a reaction time by looking at the inter-key delay, the time elapsed in between each key press as a reaction time. And if we do that, then we have to characterize what's a correct reaction time and what's an incorrect reaction time. And a correct reaction time is when you press all keys as intended and you spell the word correctly. So we can label that inter-key delay as a correct reaction time. But let's say you make a typo, and instead of spelling key, you spell tech. And then that is noted by looking at where in the data stream do we see a backspace and a correction. And that inter-key delay can be labeled as an incorrect reaction time. So I did this with some of our unmasked participants where I had about 4.4 million keystrokes over a month's worth of data in our participants. In general, the mood disorder patients had slower typing speeds as indexed by a higher inter-key delay, and they had slightly more typos. And so when we apply the drift diffusion model to this data, we see that like with the dimensional change card sort task, mood disorder folks have slower drift rates. But in contrast, they had wider boundary separation. And like what we saw before, they had slower non-decision times. And this actually lined up really nicely with data published from Lawler and colleagues in Diego Pizzagalli's lab, where they were looking at applying the drift diffusion model to a reward task. And they found that patients with depression had slower drift rates, wider boundary separations, and slower non-decision times. One of the things that I wanted to look at was, were these keyboard-derived drift rates associated with actual cognitive performance? As a sanity check, I wanted to see if drift rates derived from the dimensional change card sort task correlates with performance on the task, and it does. So it means that the model is working as expected. And then I wanted to see if the drift rate derived from our keyboard data was associated with dimensional change card sort task performance. And it was, but just in our healthy controls. We did not see this relationship in the total sample or in our mood disorder participants. In contrast, though, when we look at tasks that are performed on device, like the trail making test that's done on the phone or the go, no go task that's done on the phone, we do see that drift rate derived from the keyboard was associated with performance on the trail making test in mood disorder participants. And we also saw that it was associated with performance on the go, no go task. So it did seem to capture some aspects of on-device cognitive performance. What I've shown you is that there are some aspects of decision-making, aspects of cognitive function that can, that are typically derived from standard neuropsychological tests that we may be able to capture from passively, unobtrusively obtained data from smartphones. And the next step is to see if we can use this dense temporal sampling that we get from the fact that people use their phones throughout the day to get a daily index of decision-making capacity. Another thing that we're interested in is seeing whether any of the things that we measure on the phone are related to what we can measure in the brain with what we know in terms of neural circuits that are involved in decision-making. And then what's really interesting and exciting, and what we're sort of putting a lot of energy in looking into, is whether temporal variations in cognition, are those useful clinical markers that might be indicative of current mood state, predictors of treatment response, informed treatment selection. And all I can say is stay tuned, because we're looking at that in a number of ways. And one of the ideas is that maybe just looking at state shifts in cognitive performance is enough, right? Maybe we have to look at shifts in variance in performance, and that might be more clinically salient. One of the ways that we're looking at this is in a study called Rembrandt that I'm doing with colleagues at Vanderbilt and Pittsburgh, where we're looking at patients with late life depression who are in remission, following them longitudinally for 2 years. And we're doing mobile cognitive assessments throughout those 2 years to see if that might be a predictor of recurrence. The other thing that we're doing, and I'm excited about, is that I'm working with Leanne Williams at Stanford to see if the cognitive biotype that I talked about earlier might be an important indicator of what types of antidepressant treatment will work best, since we know that patients with executive dysfunction tend not to do well with standard pharmacotherapy. Maybe we need to augment that pharmacotherapy with things like maybe problem-solving treatment or agents like guanfacine, which might have some pro-cognitive benefits. That's what we hope to do. That's what we're planning to do. And so hopefully at some later date, you'll hear more about it. Thanks.
Thank you, Olu. That was great. And I'd like to invite Stephanie Ward and Laura Jett, 2 graduate students in the emotion training program.
Is this too loud? Perfect. Thank you so much. My mind is blown. I'm trying to narrow down my questions, but I'm really interested in the graphing techniques that you described with the, I hope I have this right, connectome manifold learning approaches. And I'm wondering about how you mentioned that this can reveal differences in brain dynamics as they pertain to emotion regulation with cognitive reappraisal. And so how might these phase-based features and more generally these graphing techniques be used to inform the development of resiliency training programs that we might be able to use prophylactically to build up more resilience versus trying to figure out what to do when someone has a lifetime of practice not using maybe more adaptive cognitive reappraisal strategies?
Yeah.
I,
There we go. Can you hear me now? All right. Yeah, that's a really good question. And you know, one of the things that we've been thinking about as a lab, and one of the reasons why we're moving more towards these sort of digital biomarkers is that they are more scalable than neuroimaging. So what I talked about where we are taking connectome data and doing, manifold learning to look at these dynamic changes in brain networks is that that's not very scalable. That's not, I don't know how applicable that would be in terms of sort of prophylactic type of treatment. And so I'm hoping that we can find sort of digital proxies of what we measure with neuroimaging, and then that might be better applied to the use case that you're talking about.
would that apply maybe in the context then of how long it's taking someone if the idea is that there's less efficiency in those people who have the longer trajectory lengths?
Yeah. So the idea is that the longer trajectory lengths are associated with more effort required to do the emotion regulation. I think that this is just one study. It needs to be replicated to see if that really applies across the board. But yeah, the idea would be that if you had some kind of marker to identify those people, those folks, then you could think about tailored ways of addressing that issue.
Thank you.
Yeah, really great talk. I was especially curious about the kind of the interplay between neuromodulation and the digital phenotyping. So you really showed the utility of both neuromodulation and digital phenotyping. So I was wondering how you could integrate these approaches in the context of precision medicine. So in other words, could you adapt neuromodulation interventions based on individual data derived from digital phenotyping?
Yeah, absolutely. I think that's one of the areas that we're interested in looking at is taking advantage of the fact that you can do these types of mobile cognitive assessments or passive cognitive assessments on a regular basis to have a more refined approach at looking at treatment response, right? So one, it's more objective. And then the other is that it allows you to be more actionable quickly. And I think that's where it can interface with neuromodulation in a really strong way.
Yeah, and then kind of just like a follow-up question to that is if digital phenotyping is combined with neuromodulation, what would be like the optimal temporal relationship between perhaps like say TACS and one of the digital therapeutics?
Yeah, that's a good question. I mean, I haven't thought about it thoroughly enough to have like a really good answer, but I can sort of speculate on if I were to design a study where I wanted to do that sort of integration. Is that, again, something like TACS, there have been some studies to deliver it as a home-based treatment, right? So you can imagine that you can maybe modulate the settings of stimulation or whatever based on whatever readout you're getting from your digital phenotyping platform. But I think that remains to be seen. I think there's still a lot of ways to figure out how best to also integrate signals, right? So that you know what kind of information to collect, how much information to collect, at what frequency you should be collecting it in a way that makes sense for the particular neuromodulation therapy that you're using.
Thank you. Maybe just one more for now. There's so much distrust right now, I feel, after COVID, particularly toward medicine and medical scientists. And I'm interested in the barriers that you may have come up against with Lumen as this it's leveraging AI to deliver psychotherapy in a time when many people don't understand AI. And then in terms of by affect, I have worked with people who have bipolar disorders that involve some level of paranoia. And I'm wondering if there was a lot of resistance to the idea of their data being passively collected.
Yeah, no, that's a great question. And there are examples from industry where that didn't go really well. So I don't know if anybody's familiar with Abilify MySite, but it was a pill for patients with schizophrenia that basically monitored all bodily functions. And so you can imagine that if you're paranoid, that's not going to be the best treatment for you. But in general, though, we find that people are really excited to participate in these studies and use these technologies because a lot of folks are using them anyway, right? And they're using ones that are not evidence-based, which is even scarier. You know, as soon as ChatGPT came out, there were, you know, therapist bots that people just created on the fly without, you know, zero evidence for its efficacy and even more important, zero evidence of its safety, right? And there have been very horrific cases of AI chatbots gone wrong. For example, the National Eating Disorders Association, they replaced a lot of their in-person counselors with a chatbot that gave dangerous advice to, you know, patients who were desperate for, you know, valuable information on how to manage their eating disorder. And so I think within the context of a study or when it's being sort of vetted by a licensed clinician, I think patients have a lot more confidence in using these tools.
Definitely. Thank you.
All right, can you hear me? Yeah. Thanks for a wonderful talk. Incredible just array of data that you're working on. And I love the translation of it and the translational potential. My question regards adolescents and young adults, and I'm particularly curious how and whether you would envision some of these metrics like keyboard strokes being applicable to that age range, given their the expertise that they
Yeah.
develop, shall we say, and how we might use other features of smartphones or social media apps to get at those sorts of questions in younger folks.
Yeah, that's a great question. And one thing that I don't think I emphasize enough is that when we do these types of analyses, they're really centered on the individual so that everybody serves as their own baseline, right? We're not really interested in comparing my typing to your typing. I'm more interested in seeing your typing today versus your typing tomorrow, so that there's sort of an internal control in how we analyze the typing data that should address some of the issues with like more proficient, you know, adolescent typers. And then folks like Randy Auerbach have, you know, they've looked at things like emoji usage in typing as well, and social media usage. And I think all of those can provide really important information and they've shown that it is predictive of mood changes, especially in the adolescent age group where, you know, the use of certain emojis. And then also that gets into tapping into the content of what people type on their smartphones, right? And they're, you know, evolving ways that can be done in a privacy preserving way. But there's a lot of valuable information that you can get from content, sort of metadata about what's been typed. So whether they're using increased use of first person pronouns, right, has been shown to be associated with depressive symptoms. So I think all of those signals are really important and will be increasingly brought to bear in informing disease course or predicting what types of treatments people will do best with. And then the BioAffect app, I believe, there's some plans to use it with the adolescent age group.
Thank you for a lovely talk. Your work is just fascinating, and I'm really excited about the potential to apply it to the interaction between emotion and brain aging. And I'm curious, given what you said that you're following people longitudinally with late life depression, how you are disentangling cognitive decline and perhaps depression or other kinds of mood disorders. And if you or others are using these techniques to start seeing whether you can predict trajectories to neurodegeneration, Alzheimer's disease, or other neurodegenerative disorders. It seems like given the accumulating evidence of vision changes, changes in speech patterns, that this could add another piece of crucial data to identify who's at risk and where to intervene, not just for depression, anxiety, and other mood disorders, but Alzheimer's and other disease risk.
Yeah, that's a great question. With regards to our Rembrandt study, which is our late life depression study, we're very interested in seeing how some of the measures that we're looking at as predictors of recurrence, how that overlaps with predictors of cognitive decline. Just as sort of a spoiler alert, we're not over the 2-year follow-up period, we're not seeing huge changes in cognitive function. And that's why we feel like looking at the variation in cognitive function over that 2-year span might be more informative. But we're also getting some blood-based biomarkers of cognitive decline risk. But that's a really huge area of inquiry, and people are really interested in teasing that out. There's some work out of University of Toronto by Tarek Raji, where they've looked at using cognitive remediation plus transcranial direct current stimulation to prevent cognitive decline in patients with older patients with a history of depression. And what they find is that it works in general, but it doesn't work if you have a risk factor for Alzheimer's, like your ApoE status. And so it suggests that there might be different flavors of cognitive decline, some that might be more down the straight Alzheimer's neurocognitive disorder path, but there might be a depression-related cognitive decline that occurs later on in life, but that might be more amenable to interventions. And then you asked another question about using this type of typing assessment more broadly, and it's been used in multiple sclerosis. I have a colleague, Rhianne Moore at UCSD, who's shown some preliminary differences in patients with mild cognitive impairment. And again, that gets to sort of the central thesis of the UNMasked study, which is when we're looking at these typing metrics in association with mood states, it's really cognition that we're measuring and not, mania or depression.
Hello, Princess Felix, University of Michigan. Thank you for your talk. I'm thinking about people who would use the Unmasked app to kind of track their mood states online when they're interacting, but I don't know if you heard of like people who have almost different voices or personalities when they are typing versus speaking in person, because I encounter people like that a lot, especially in the younger groups. A lot of my undergrads who I teach are very different when they are speaking to me versus typing or engaging online. They might seem more confident, more erratic, more faster typing and getting their ideas across in that way than actually interacting face to face. And I see that a lot in younger people. And I want to know if there's a way to account for this, how one's almost personality is different digitally versus in person, and also what that would say about their mood or some phenotypes that they might have.
Yeah, that's a great question. And, it's important to state that we're not capturing what people are typing. So the content, we don't know, right? But I think you do bring up the important question about the context of the typing, right? Like, am I typing an email or am I sending a quick, text, text message to a friend? And so we've always struck this balance between capturing too much information and being too invasive versus wanting to know more. And they're now, I think on the iOS platform, it tells you a little bit more about different app usage. And so we can infer what apps were open when somebody was typing. And we're starting to look into that a little bit. But we're always, to the question before about privacy and issues, related to people's concern, valid concerns about that, we're very careful about not trying to dig too deep, even though a lot of this information is available, right? Your iOS knows all this stuff, Google knows all this stuff, Facebook knows all this stuff, but we're trying to be mindful of the privacy concerns.
Hi, Dr. Ajilore. Thank you so much for your talk. I work with Dr. John Stanley, so a lot of the
Oh,
work
okay.
that you mentioned is like very dear and heart to me. I guess my question pertains to whether there's any within person associations between, like, for instance, typing dynamics and I don't know, affect or like symptoms of depression. Because what you showed is that there's like between person association between, for instance, the number of typos you make and their depressive symptoms, right? And I'm curious whether, like, for instance, in moments when someone makes more typo, whether that also correlates with like an increase in negative affect or like depressive symptoms, et cetera.
Yeah, that's a great question. And in the unmasked study, we do EMA where we're asking about mood regularly. And so we have some preliminary data suggestive of a cross-lagged association between typing dynamics predicting mood the next day. So there's a hint of a signal there related to that. Yeah.
This is a really interesting talk, and I think you've done so much incredible stuff in such a short time with a field that's, in terms of digital biometrics and digital typing, that's so new. One of the questions I had for you is that NIH is slowly but increasingly appreciating that we're living in a really digital world, and we are constantly using devices like this all the time, and they're increasingly expecting, or putting out feelers for this type of research. Can you talk about, in your lab and in your career, the learning curve or the logistics or the ability to get up and running, developing apps, developing these kind of novel interventions? Because it's not easy, and it's being expected of scientists working in, with humans now. And it just seems like such a challenge for anybody but the largest organizations and largest labs. And I was wondering if you could speak to what that's been like in your group.
Yeah, and you bring up a good question, and I serve on council for NIMH, and this came up at our last meeting about, how to handle, just even handling the data, right? That comes from all these devices in the context of NIMH funded studies. How do we kind of standardize how the data is collected, stored, so that it can be kind of more democratized, right? And so that people who don't have large resources won't be disadvantaged in how they utilize or analyze the data. And people made the analogy to what's done in neuroimaging, right? Where you have a standardized file format, right? Where we can save, neuroimaging files, and that something similar is needed for all this digital exhaust data that we're collecting from smartwatches and smartphones and Fitbits. And then it's complicated by the fact that a lot of these things are controlled by private industry partners that have, proprietary algorithms or formats. And so I think there are a lot of barriers, but just to know that NIMH is thinking about it. I don't know if they have any good answers yet. But with regards to, what kind of tools are available out there, increasingly, there are folks like, John Puros, who has MindLab, making these things available for, folks. For example, the BioEffect app, we have collaborators that they don't pay a lot of money to use it. It's just basically the cost of storing the data on the server. So, a lot of these federally funded projects, make these tools available at low or no cost.
So you just mentioned the EMA. I'm curious if you see any changes in the key press patterns with changes in affect, or, for example, if somebody has encountered a stressful event, and so that you could track their stress reactivity regulation kind of time course with key presses that could inform us about individual differences. Yeah,
I wish we did that. Now we're gonna do it. Now that because your question brought it up, I was like, oh yeah, we should capture that too. But unfortunately we didn't get that to get more of the context, but I think that's a great idea.
Yeah, thank you. I'm going to really be analyzing how I'm typing on my phone now. I know a lot of your research right now is more focused around like the data collection portion, but I was wondering if at some point there's thought to like integrating the apps themselves into like part of like the interventional, like even just sending a push notification, just being like, hey, you haven't hit backspace in a while, you good? Like,
Yeah, no, I mean, yeah, so I think about how to integrate like what we're capturing from, from typing. It could be from other things. It might be from GPS data, right, on your smartphone. But the idea is that you can have a single device that's used for assessment and treatment, right? Might be the Healthy Minds app, right? You might have some tool that's on your smartphone that gets triggered based on the data collected by your phone. Yeah, I think that's a natural pairing of sort of the different things that we've been doing, and others are doing that work already, where they're doing just-in-time adaptive interventions based on data collected from either smartwatches or smartphones.
I have a really simple question. So with all the smartphone and digital technology for interventions, how do you balance an in-person consultation and the repeat therapy sessions with something like the homework part of it, which is probably the online or the electronic way of doing this?
Yeah, so I think one is when I think about actual, implementation or eventual dissemination of something like Lumen, it would be meant for people as designed in the study for folks with mild to moderate depression and anxiety. It wouldn't be for people with more severe cases. And there have been a ton of studies that show even when you're deploying things like internet-based CBT or digital CBT, those interventions don't work unless you have some kind of human in the loop, some coach to encourage people to follow up with whatever modules they're supposed to be doing. That makes all the difference. So you still need to, they don't work as standalone interventions, at least not yet.
Thanks for an amazing body of work. I'm wondering, I think that these digital therapeutics and tracking apps seem like they pose a problem for evidence-based medicine, because if you want to study a particular treatment program or particular assessment, with the apps, they get privatized and it becomes a moving target, right? That it's under control, it's a black box. It can change at any time, so you don't know if you're studying the same thing when you're studying these different apps. So I'm just curious about your thoughts about how you approach that.
Yeah, no, I think that's a really good question, and it brings to mind the idea that there might have to be, when things get either FDA approved, right, as a digital therapeutic, that those products get locked. And the evidence base that led to an FDA approval is for that device as submitted. And so that they wouldn't be able to make changes, and so that you'd have maybe more confidence that, okay, well, if the FDA said this is what's approved for this indication, when I download this device or when I'm digitally prescribing this device or intervention, it's the same thing. It hasn't been updated, hasn't been changed, hasn't been modified. That might be part of the requirements, right? That regulatory requirements involved in some kind of approval. But there have been a lot of regulatory hurdles to getting digital therapeutics sort of deployed and used. People don't know how to prescribe them. People don't know how to get reimbursed for them. So, there's still a lot of hurdles to even having that kind of stamp of approval that would require, interventions to be locked down.
Hello. Great talk and really amazing work. I'm just thinking about heavy phone users versus non-heavy phone users and generational differences within that. And as you start to look at app usage and content, like who is using like social media apps a lot versus not, and if they're just like generational or just like mental health differences of like how you're getting your social interaction potentially like throughout your life and day in like a physical face to face
Right.
versus online. And if
Like
that
whether
has
it's a
implications.
substitute, right? So
Yeah.
I think like, again, Randy Auerbach has done a lot of thinking and work in this area. And most of what he's shown is that it's literally a double-edged sword, right? It exacerbates mental health problems for some people. It alleviates mental health problems for others, right? And it's not the use in and of itself, but it's maybe how it's used and who it's used with, right?
Thank you for such an intriguing presentation. You mentioned CBT, and in CBT, we change the way that we give attention to thoughts and change the way that we behave. Do you think it could be an effective treatment to change the way we give attention to certain notifications or change the way that we type?
Oh, that's a good question. Yeah. As I think about it, I think that my phone is on silent right now so that I could focus on answering these questions. But yeah, I think I think it depends if, you know, I wouldn't pay too much attention to how we type, right? Because the idea is that this is supposed to be your naturalistic behavior that we're capturing, right? So if you pay too much attention to it and then you change the nature of your typing, then you change the quality of what we're getting from that typing data, right? But with the notifications, again, I think it's how people respond to notifications, right? Because I know for a lot of people, notifications can be very triggering, right? And so that might be an important focus of the therapy. For others, they might not be as bothered by it, but it's a good question.
So Olu, thank you so much. That was really wonderful. And I love the new direction of the work. And I also appreciate the call out to the Healthy Minds program. We're very much immersed in this space ourselves. And one of the questions that I wanted to ask is, and I sort of, I intuitively know the answer, but I'd love to hear your thoughts about that. And that is that you clearly are interested in assessing features in the emotion, mood, emotion regulation space. And the primary digital measure that you're looking at involves basically typing. I think if you were putting aside digital technology and just thinking from first principles, what would be the features that you would look at to measure affective behavior? The first choice wouldn't be typing. And so I just wonder, what your thoughts are about that and where you see this going. And where, just to give a little preview, we've been doing some work now where instead of conventional experience sampling where a person is responding to a question, we actually have them create a 10-second video about how they're feeling right now.
Yeah.
And the amount of data in a 10-second video is just extraordinarily rich. And you can also have a person, people are looking at YouTube videos all the time on their phone, and you can have a common stimulus and look at their affective response to that stimulus in a way that's very easily scalable. So I just wonder what your thoughts are about those kinds of approaches.
Yeah, no, I think those approaches are very valuable. And one of the things that we've been interested in looking at because of the pandemic, we switched a lot of our in-person assessments for our studies to Zoom, right? And that provides a rich source of audiovisual data that could be fed into these machine learning models to look at affect or to look at predicting affective course. And so I totally agree. And I think ultimately what will work best is a kind of multimodal solution where we integrate all of these inputs, right? And not be just focused on one. I think we started with typing because this was Dr. Alex Liao's idea. She's a pianist. And so she was inspired by her wonderful piano playing and how she expressed her emotions through her fingers and how that might be related to typing. But I think, and again, I agree that the typing is not what you would think of when you think of tracking affective symptoms, which is why I think what we're actually tracking is cognition, All right. Thank you.
Thank you so much. Let me go run my I just read the proposal. Thank you so much.